touch a lot of different areas in the center. So really excited to hear about your guys' experience.
There's not enough of a Leah to go around to help us all, put it that way.
Well, I think we've gotten through everybody. I'm gonna see if I can share my, so actually maybe I'll introduce myself, and I'll have Cindy introduce herself. I'm Julie Benson. I've been a family medicine physician in rural Minnesota, in Staples, a town of about 3,000. I'll go through some of our demographics in a little bit here, for the last 27 years, which means you've been here that long too. So we joined Lakewood about the same time. And working on some form of palliative care for a chunk of that. I don't even know where we're at, maybe 13 years. No, we're longer than that. Yeah. No, we're probably in the 15, 16 year category. Not to the same level that it necessarily is across the country, but having some interest in it for a long period of time. I've sat on the Minnesota Network of Hospice and Palliative Care Board. That's Minnesota's network and agency to promote hospice and palliative care initiatives and education. We have conferences, we have networking opportunities. I sat on that board for 9 years and continued to do some committee work with them. It's been a great experience. I sit on the Palliative Care Advisory Council as well for the state of Minnesota, and have done that for the last 7 years. It's really exciting for me that you have some representation here on for your advisory council as well, because each state really does some very interesting and different things along those lines. And so kind of fun to have. Usually when we do these presentations, it's to specific health teams and specific clinics. So this might actually be a little bit interesting, and maybe we will get into the weeds too much, maybe not enough, we'll see, but some of this might make sense to you in a little bit of a different way than in other presentations. I'll let Cindy go.
I'm Cindy. I'm a registered nurse. I, as Dr. Benson has said, been here for 27 years. Also, I worked in many different areas prior to being hired on full time in the palliative care role in 2009, January of 2009. And so since that time, we've been building this program. It has changed a lot, and it continues to change. And we are, I'm doing oncology palliative care right now. As of last year, I took on this role. So we're building the oncology palliative care program. So that's where I'll stop, and then we'll start our presentation.
I'm going to try and share my screen. I'm super techie.
You should be able to.
Let's try this. Okay, slideshow. Right from the beginning. Let's try this. Can you see my slides? Right? Dang it, you can still see me. You too. Okay, so actually, because I can't see everybody, I actually would be very okay with this being a really open conversation. So I tend to talk fast, and I kind of will through some of our demographics, because you can certainly go back and look at it, but please either hold up your hand, or I don't even care if you just say, wait a second, I have a question. This is a really good place to have some conversations. We have plenty of time, I think, to walk through some of these things. And so I would rather have this be an ongoing conversation. So I don't consider an interruption if you say, hey, can you tell me a little bit more about that? Because we're more likely to get into a conversation that's going to be valuable to you than what I think might be valuable to you. Does that make sense? So please, let's just talk through this whole thing as we walk through it. All right, let me see if I can figure this out now. There we go. Oh, I start every single one of my presentations with this. Janelle and Carla are probably sick of seeing my quote that I have used for dozens of years, it seems like, to cure sometimes, relieve often, and comfort always. And that's kind of what motivates us to move forward. I'm going to probably be speaking to the choir on some of these things, but I'm going to give just a little bit of background. This little diagram has morphed over the years. Like Cindy says, when you're building something, you actually continue to build and change and morph, and this should too. So when I talk to people about palliative care, I want them to be very clear about the pre-hospice component of this. That's how some people really think about it, but it is really much more than pre-hospice. It really can be at the time of a serious or potentially life-limiting disease. And I've moved some of my language even to move into serious illness, as opposed to pre-hospice or life-limiting diseases. And I think sometimes that makes it a little bit more palatable for our teams. So Minnesota, a couple states over, we are located smack dab in the middle of the state. Staples is a population of around 3,000. But we serve around 38,000, depending on how you look at our service area. We border 4 counties. We are a critical access hospital. I'm in a rural health clinic. And so I'm excited to have somebody who understands the even terms about rural health clinics and critical access hospitals, because it's weird and there's weird regulations about all of this. And so it does impact us at times. We have 5 clinics, we have Staples, and then we have 4 satellite clinics. Some are 11 to 12 miles away, some are 20 some miles away. We have I would say, a robust senior service line. We have a long-term care. I look now and I see I did not update it. We used to have 100 beds. During COVID, we actually downsized to about 78 beds. We do have a secure dementia unit. We have 2 assisted living facilities, around 65 apartments and boarding rooms. We have a home care hospice line. We have ambulance, non-emergent transportation, and a few other things. But I think I really want to focus today a little bit more on building a cancer center. And truthfully, I believe that part of our ability to build this cancer center, I'm not going to say it's based on our ability to provide palliative care, but I think that was one of the sort of key aha moments for when we kind of get into this story a little bit about why this might even be, if Lakewood can be innovative around serious illness care, they can be innovative around cancer. So this tiny little town is literally, I should have gone to take a picture of what it looks like right now. Our radiation unit is enclosed with its cement, and there's I-beams all over, and it's very exciting for where we're going in the future.
Hey, Dr. Benson, John Barnes,
Yeah.
who's your tertiary care partner? Where do you transfer most of your patients to?
So depends on the day and depends on what we're talking about. And everything is about 1 to 2 hours away. So St. Cloud is a little over an hour away. We have Duluth, which is about 2 hours away. And we have Fargo Moorhead area, which is about 2 hours away, 2.5 hours away, the Twin Cities of St. Paul, Minneapolis. So it depends on whether we're transferring trauma, heart, transplant. We have Mayo about 4 hours away by ground, a little over an hour by helicopter. So we actually transfer all over the place.
Well, you guys are very isolated.
I think that sounds like we're not, but I think that's really interesting. Yeah, when I talk to some places, they're like, we are 4.5 hours away from the closest. And I'm like, we are in this little epicenter and we can go almost any direction. We are half an hour from Brainerd, which is a town of about 30,000. Yeah. They do have a radiation center. They do provide they are part of Essentia, which is a very large health system out of Duluth and northern Wisconsin over into the North Dakota area. We're kind of in a watershed area, because if we wanted to be owned by somebody, we would probably have 4 different large health systems knocking on our door.
Do you use swing beds?
We do. And on my long-term care, I actually have post-acute rehab. Mm-hmm.
And you own your ambulance service too.
We do.
Good for you guys.
Yeah, it's
do you get cost based on it because of your location?
Yes, I believe. I'm going to say I'm not in admin stuff anymore, but I believe that is still our payment source, or our model. Mm-hmm.
That's awesome. All right, thank you very much.
Yeah. We are probably, and I haven't looked at this in a long time, but we are probably the largest critical access hospital system in Minnesota, and probably, maybe Carla knows a little bit more about it. We're probably one of the largest and fairly robust in its service lines. So I just put up our slides. I don't even know if this is accurate anymore, because I did it last week, and I swear we are constantly adding new people. So, but we are very primary care, family-centered based. Our board has physicians on it. Our executive board for the medical team is always family practice heavy. We are always going to be primary care based. And so, but this is just kind of our demographics for the moment. They change. Actually, I think one of our dermatologists is leaving, but I think we're adding somebody. So that news just came out yesterday. So this is kind of where we're at for the moment. Of note, right now we have 2 oncologists. Our oncologist team, and I think Cindy will get into that a little bit more, but that is how we're growing rapidly. So most places this size don't have 2 oncologists or 3 onc NPs, which is kind of exciting.
Are you part of an accountable care organization?
Yes. Ooh, this is going to get hard. We are, let's see, we are part of Aledade,
Yep.
which is the kind of, I don't know how I get it described to me, you probably understand it better, is an accountable care organization for smaller groups, correct?
Yes, yes.
So we are part of Validate. We do not, I don't know how many lives we have in that. I'm gonna say it's less than 2,000, but I'm not positive. And that might make more sense to you than it does to me.
Thank you.
Okay. All right, so I do talk fast, and I'll kind of run through this. We started talking about palliative care actually back in 2005. And that was a term I really had never heard of except for end of life care. Didn't really understand what it could be as a service line until some of my hospice nurses came to me and said, look, we know that people qualify for hospice, but they won't do it for a variety of reasons, including they don't want to stop specific goal-oriented treatment, but there's got to be some other way to take care of them. And so we started talking about this really more as a bridge program. And I just got a little bit of education. We kind of bounced around in home care. We started talking about people who were not enrolled in hospice, but who needed sort of that interdisciplinary, transdisciplinary care, and probably started doing palliative care before we even called it that or even knew what it really was. And then in 2007, we actually received some grant money to begin to develop a palliative care program. And I'm going to say this because it actually happened in reverse. I started thinking a little bit about palliative care, wanted to get some training. And then one of my partners came to me and said, hey, I got handed this money, this grant. Do you think you could write something that's about palliative care? And then if we can make it legit. So it was very interesting. We got money right away to do some education and to do some exploring into this.
It's fine with you.
Pardon?
Want to talk at the meeting, but if you're busy, that's okay. Well, I'll get back with you sometime. Take care.
All right. And then during the course of the next few years, we started working with Stratus to begin the Rural Palliative Care initiative. And we were quite blessed really to meet this team. I think they were instrumental in us sort of getting our ducks in a row, helping us put some structure into what this could potentially look like at a time when there wasn't really anybody else to look at, a time when if you Googled it, there was Stratus. That was kind of it. There really wasn't a lot of information out there. So we were really lucky. We started our pilot program. We hired Cindy in 2009. Our pilot program really included mostly our infusion team. And I don't know if you want to talk a little bit more about that.
Well, when we went through, we had meeting after meeting after meeting, and we just finally said, we have to start. We just have to begin because we don't know what we're going to find until we start. And so that was one of the first areas, was the infusion team. And we went to them and asked for 5 people to identify somebody who maybe needed some extra support, some symptom management, those kinds of things. And we got those names and we started with them, and it was a learning. It was learning, but it was helping them. And we learned fast and we helped them. We supported them. We would go to their home and meet with them if there was a need. Otherwise, we'd meet with them when they'd come into infusion therapy. It was a collaborative effort. And one of the main things I will say, and maybe I could talk later too about it, is one of the things we learned is I was just hired as the RN. We didn't have social worker or chaplain at that point, but I remember a patient specifically that they kept having more pain and more pain and more pain. And we brought on social worker, and she was able to fix some financial things for them or get them some resources, and that pain melted away. And not that it went totally away, because she did have true physical pain, but that just shows how this all compounds the emotional side, even the spiritual side, it all makes a difference. And then shortly after that, we added the spiritual component, and that same thing happened. So I'm just saying that right now, that we started with infusion with an RN and a doctor, but we very quickly needed more support and better support, and we got it all.
And I think one of the lessons for me as well is I was getting super excited to kind of, what can I do? I can kind of practice some of these new skills. And it was all RN and social work needs. Like I was just kind of in the background going, way to go team, you're awesome. Because it is so important to have that interdisciplinary component. And so, and like she said, we learned a lot. Between 2008 and 10, our goals were, this is the palliative care initiative, sorry, and you know this, so I'm going to probably run through this because it's not, it's all the information that they've probably given you, but they really gave us some strategies using the National Equality Forum, looking at community capacity, looking at creative staffing were some of the ways we kind of looked at this. So how to start, how you guys start, or how you teach other people to start may vary. This has been our experience. And again, it's changed. And I think there's just a little bit of context. And maybe Carly, you know a little bit better. I don't remember exactly when healthcare homes were becoming a thing and in development, but to some degree, kind of around that time. And so I feel like we were building a time when people were also really looking at trying to get a grasp around taking care of people in a more comprehensive way. Healthcare homes was sort of having some of its early labor pains, trying to figure some of those things out too. There was some scaffolding to build off of that. And again, still, there really wasn't much for palliative care. So we kind of developed some points here to kind of walk through some of the things. So we'll talk each about the venues of care, the interdisciplinary team, models of care, and we'll go through that. We'll start with venues of care.
So we started, like I mentioned, with infusion therapy. And then after we felt like we had that under our hats a little bit, we went to the care center and we said, hey, give us 5 people. We were at the number 5. That was just a number we just chose. We went with 5 residents, and we learned again along the way, but we had the whole team. And at the care center, we had RN social workers. From there, we had the chaplain here at our facility, because we're small enough. He serves all of us. He serves the hospital, the care center, infusion therapy. He goes everywhere as needed, in hospice. I mean, and that's a big part of his time. But we kept developing and educating, and we were working with them. We integrated a lot of complementary care. We did massages, we did the oils, we've done those kinds of things. And a lot of those were helpful for different people. Each person, it's so important. Each person has their own need. And the importance of the team is somebody may come up with an idea. And I'm just going to give one quick example, because I'll never forget this one, where this patient just screamed and screamed and screamed when she was getting a shower. And long story short, when she was younger, she nearly drowned. So we put her in a tub instead, and that all cured. Now, is that totally palliative care? No, but what it is, palliative care takes time. So it's sitting down and really getting to know that person, getting to know their family. It's that network, it's that relationship. The relationship is so important. And hearing what the care center staff, the importance, the things that they were telling us. Okay, so what are the things we can do? How can we support this resident and their family? And so we did that. And with that education, we have gotten to the point right now, because I've been out of community palliative care for a year and a half. Now, with all the education that's going on in the care center with palliative care, it's embedded. We don't go there anymore to see our residents. The staff there know how to do the conversations, goals of care, quality of life. And the thing I think can be confusing is we can all say we can do that. Oops,
Mhm.
sorry. But there is more to it. There's a lot more to it. And it's really sitting down and doing that, listening from your heart, ears, and eyes, and getting to know that person.
Yeah. I would really agree. I think some of the stuff that we've done through long-term care has actually been a success story about embedding that care and raising all boats. We also provide palliative care through our home care hospice. So that team is a home-based palliative care team. It is our hospice. Our home care and hospice are the same group of women, because we have all women, and they're amazing. And they do both of those things. So they often have some of these conversations even with our home care clientele. We also have an NP who does home visits for home care and hospice. She's a former hospice RN, so she's extremely adept at having some of these conversations. In our outpatient services, that's our community-based palliative care, and then inpatient services. We do have inpatient palliative care opportunities. It tends to be less medicine focused and more onboarding of the community base and helping them try to figure out the next venue of care. And so most of that is done actually by our RN team and our social workers and chaplain. Interdisciplinary team, when we first started, it was the two of us. We added others as available. What I often encourage places when they're starting to think about some of these things, and again, where you might come into play, is be creative with staffing. You don't have to necessarily have to hire somebody right on the get-go. Borrow some expertise. You might have a pharmacist that's excited about this, and they can maybe run some medication reviews for you, specifically looking at palliative care. Have them work with maybe an RN to help with some things. You don't necessarily have to hire for these things, and we don't always have specific positions always hired. We have RN case managers. We do now have a social worker. Our chaplain, as Cindy said, crosses all venues of care in a variety of hats. I serve as the medical director, but that's not my only hat by any stretch of the imagination. Our pharmacists, our volunteers, our therapists will come to the table on some of these things. So really be creative. In some situations, we are leveraging our medical home RNs when we don't have, maybe when we have some capacity issues. We are leveraging our home care RNs, our long-term care staff. So be creative in staffing. You don't have to hire for every specific position of the interdisciplinary team. Oncology IDT, this is now branched off in the past year and a half. So you can chat about it.
Yeah, we follow what we have done with community-based palliative care. So it's myself as the RN case manager, oncology, palliative care, social worker. Our social worker works with all of the oncology patients. However, she definitely helps out a lot with the palliative care, and we are looking at potentially needing to add on for that so she can get some extra support. And then we have our chaplain and our pharmacist we can go to at any time and see what our needs are. They can tell us whatever we are needing at that time. Our medical director, Dr. Benson, sits in on those, as does one of our oncologists, and our 3 nurse practitioners are always in. And then the oncology case managers, we have 2 of them. We are right in the process right now of adding on new staff and beefing up the program even more. So they'll be coming on. And then our infusion nurses, because they're very busy, typically they all do not participate, but we may have 1 or 2 that come online so we can get information from them, because they may see another aspect component that we need to consider.
Yeah, absolutely. So models of care really didn't exist, as I alluded to earlier. Our belief when we were trying to decide how to create this model of care was that we believed palliative care was an ongoing process and not an episodic care. We were not super interested in consultations only and then moving on from there. So we sort of adopted what I'm calling the hospice model of care, which was ongoing care, interdisciplinary team meetings. We've used every 2 weeks because that's what's required for hospice, but that also sort of keeps us on topic, looking at plans of care and that these are updated, making sure that our attending provider continues to provide care. So I do not provide all of the care for our palliative care patients. Their PCP really is integral in some of these things, but we don't require them to come to the meeting, but we make sure that we communicate with them. making sure that we have some sense of closed loop communication with this. Also, there really are no CMS guidelines to follow, and there are no certifications, which is great, and also not so great because you're trying to figure some of these things out, navigate through that. Our comprehensive care center, as we're building this with cancer, is super exciting. We have been, prior to this development for us, we have been getting our cancer care via Community Connect type resources. So neighboring facilities, Essentia did our cancer care for a while. We had Centricare doing our cancer care for a while, and it was tough. We had people coming in one day a week, maybe once every other week. We were having troubles with continuity of communication and care. It just never really fit our model of really trying to provide ongoing good quality care here. And we had actually been we actually had our last Essentia stepped out of this. They lost a few of their providers and needed to pull back their outreach program. And so we actually were without any oncology care for a short period of time when we were rapidly recruiting, trying very hard. It's hard to get somebody to come to rural Minnesota, as I'm sure it is for Michigan. And we actually were, we had reached out to someone who had been providing care in a couple communities over. He said he really didn't have capacity to do that, but eventually gave in and said he would come in, at least take a peek and see what kind of capacity they could build over the next year. And then as he sort of took a look at the mission of what Lakewood is doing, and again, I don't believe that palliative care commitment actually put the nail in the coffin over him just choosing to join us, but I think he highlighted some of our progressive and innovative thoughts around comprehensive care for our patients in general, and also our commitment to community. So it's not just patients that come into us, but our commitment to health overall of our community. So he joined us, and rapidly we built a team. We added the dedicated RN, palliative care RN, which I'm super excited about. And that's the role that Cindy has taken on now, our care coordinators. And then next spring, we are adding a board certified, fellowship trained palliative care physician. And this is all he's going to do is palliative care, whereas I dabble in this all over the place, depending on what hat I'm wearing on what day of the week. And so I'm super excited about this. He's working in an embedded clinic right now in Michigan, actually, sorry. I just realized that. His wife is finishing actually she just finished her rheumatology fellowship. So we were recruiting her, and she was like, well, I would love to come to rural Minnesota, but my husband does palliative care and you're not going to have a space for that, are you? And we went, actually, we do. So he is going to be embedded in our oncology or cancer center with the ability to do comprehensive palliative care for our heart failure patients, for our renal failure patients, for our pulmonary failure. Like, he's going to do all of it, but he will be situated within oncology. And right now, we don't know what that's going to look like exactly, but we're super excited about it. What did I miss? Go ahead.
Dr. Benson, yeah, it's John again. What are the major industries in your community or county?
Us.
So they're in the schools and county workers.
We have our school is one of the bigger employers, but it's not a humongous school system. We do have a community college. Central Lakes College is one of our schools here. Pardon?
Sourcewell.
We have Sourcewell, which is I don't know what to call that. It's an ACO for education kind of thing, shared purchasing power, things like that. We have a 3M building here. We have a few small industries, but we are on the border of some very large tourist areas. Yeah. So Brainerd is about half an hour from here, and we have lots of tourism over there because that's the lakes area. Where we are mostly farming, but we are really on the edge of that tourism.
Got it. Okay. So no timber or anything like that.
I mean, there's potatoes and timber and all that stuff around us. They're just not major.
Okay. Thank you.
Yeah. There's a lot of farming around us. Your potatoes for your French fries from McDonald's come from around here. Really good potatoes. Other models of care that we kind of looked at: inpatient, outpatient, home-based care, long-term care, cancer center, consultative. We looked at all of these things to try and see what makes sense. Some small communities that have been successful in building some of their palliative care have focused mostly on inpatient or mostly on home care based or long-term care. So I don't think it's right or wrong. So, and as you are educating some of your teams and supporting them, instead of trying to do everything, pick a spot and have them work on some of those things. But you can choose any place and focus on that, focus on the education. Our services, this might be getting into the weeds a little bit too much. We do have some admission packet information. The primary support is telephonic support unless they are in the home and home care based. So proactive, and to some degree similar to maybe how you might manage some medical home type or coordinated care, except we're much more aggressive. We have a smaller group of patients, and we're much more proactive and following up with people on a regular basis and coming to some of those appointments, meeting them if they need to. So we'll do some support in their clinic or their specialty visits. If somebody ends up in our ED and we're able to during the day to run in and help coordinate care, we can do that. I think we're pretty good at really working on transitions of care when patients are needing a transition to assisted living, long-term care, those types of things. They are very good at coordinating some of those things. Family meetings tend to be something that's very common. Of course, we work on advanced care planning and Pulse, and then we have an active grief support program as well. So strategies to develop this is also very variable. But again, when we started this, I had administrative buy-in faster than I expected to. And I'll talk about that a little bit more in a second, but that is absolutely key, is having some administrative buy-in somewhere at these communities that you guys are talking about. And we'll talk a little bit about how to kind of work with that. Building a palliative care team and case manager model, I think is important, but a team has to be at least 2 people. You can't have, I don't believe you can have palliative care offered by one person. It really does focus on interdisciplinary care. You're gonna have to work on.
Were those 2 team members, were they the champions in your organization?
Yeah, so that was Cindy and I, and quickly pulled in a social worker.
Got it. Okay.
Yep. Education of your staff and public is ongoing. This is a constant thing that we're doing, because I will say, even as long as we've been doing this, my partners still kind of go, oh no, they're not ready for palliative care yet. They still think it's pre-hospice. So it can be complicated as well. So this is ongoing. Whenever when we onboard new staff, so my new nurse practitioners, my new PAs, and my new partners that come on, even if they're coming into a specialty level, I have them meet with me for just a short period of time to talk about the difference between palliative care, hospice, how to access it, a little bit about what we have, and then I give them, probably more than they want, resources for other things to access if they want to learn a little bit more about it. But you have to do ongoing staff, because and you probably are aware that, again, the medical community still really doesn't get what palliative care is overall. And then some public education. We use
And do you have standard training for that all of your new nurses or social workers go through when you talked about kind of the embedding it in the long-term care? Like, how are you?
Yeah, they meet with me.
Okay. Okay.
So not necessarily standardized, because COVID changed a lot of that, as you might see. And so some of that kind of fell to the wayside. We tried to get them to do some standard education, but I will say, whenever we mandate education, I mean, if you are an employee within any of our health systems, the amount of mandated education you have to do on, I don't care if it's fire alarms and HIPAA, and it's daunting. And so I've tried really hard to implement some of these types of mandated care for everybody. It's really hard to do. And so we haven't mandated it. We try to do exposure ongoing. And then when I have new staff, if I get a chance to work with them, in fact, just right before we sat down, I have a new PA that's working with us. And I said, by the way, I sent you an email about doing some serious illness conversation training. It's free. Please do this. It's offered by the Center to Advance Serious Illness Care in Minnesota right now. So she's like, oh yeah, I'll look at that. So it still has to be grassroots.
Yeah, okay, thanks. I just know
Yeah.
that building skill capacity piece is so important.
It really is. And if I had my druthers, we would look at this. And the other hat that I wear from the Palliative Care Advisory Council, we actually looked at trying to require, much like we've had to require opioid training, right? I think 2 hours of opioid training for my licensure every year. We looked at actually trying to do something about palliative care and end of life or serious illness conversations even. And the appetite for that is minimal, because there's so much required stuff already right now that we actually dropped that. But that was actually one of our Palliative Care Advisory Council early on was like, hey, we should make this part of our licensing for providers, for anyone who's licensed through the state of Minnesota. And we dropped it because of such distaste. And again, it was probably just the timing with COVID and the opioid epidemic.
Hey, Dr. Benson, just for my own education here, where is that gray, cloudy, murky area between pain management and palliative care?
It remains gray and cloudy and murky.
Okay.
I will say that I struggle with it even personally, and I think a lot of palliative care docs do as well. When we talk about serious illness, someone who has chronic pain, that is serious. Many in the palliative care world try to separate that out and say, if you don't have sort of something I can put my fingers on, as far as an end-stage organ disease or a progressively end-stage organ disease, whether it's dementia or whatever, they will struggle with doing some of that because it's a slippery slope into pain management. I should have noted, we actually have a pain management team with anesthesia, nurse practitioners who do a lot of, I will say, mostly procedural based pain management and some pharmacologic pain management. But we actually don't overlap a ton, except I will maybe consult with them when I think I've got something in a palliative care patient that might be managed well. But it continues to be a gray zone, and some palliative care docs want nothing to do with chronic pain management unless it has to do with serious illness. It's tough.
Thank you.
Yeah, it's tough. We use the 8 domains of palliative care from the National Quality Forum. I just refer people to that all the time, and that got updated not terribly long ago, and that looked at a little bit more sort of community care, which I think was really good. Quality metrics, we talk about this a lot. We've been doing this a long time, and quality metrics are some of the hardest things for us to get because we have changed our software system 3 times in the last 10, 12 years. There are so many other priorities when it comes to quality metrics. It's been very hard for us to grab some of those quality metrics, but it will show some of the numbers that we had from back in the day when we did a study with Stratus as well. Leadership is strategically important. Creative staffing, I've talked a little bit about that. I think that's one of the places I would really focus on is creative staffing, hardwiring some of your palliative care principles, and then workforce development, I think is key. And again, COVID highlighted a lot of our workforce issues and the crisis around workforce development, particularly in rural areas. We often can't compete with the, $50 an hour nursing that you might get in some of the larger cities. But workforce development is critically important. And so we do a lot of teaching. We are actually a teaching location as well. And so our medical students, our nursing students, we try to get in and get them some background information on palliative care, on serious illness care, those types of things. But it's worth the investment in your workforce as well. Administrative buy-in.
I was just interested in hearing more about the education that you did for the public, especially as you were starting your programs.
So we did a couple of things when I'm trying to remember when Atul Gawande's book Being Mortal came out. I wonder if I might even have it in here. I can't remember. There was a film that went along with that. We actually did some conversations around that. We developed a panel. We showed his film. We had some patients do some presentations about sort of testimonials. We offered a couple of different opportunities for people to come in, have some conversations about this, develop maybe even their own advanced care plans. We sometimes paired it around, I believe April is National Healthcare Decision Month or week or day, somewhere in there. We've done some, nothing that's been unfortunately on the calendar every single month, but November coming up is National Hospice and Palliative Care Month, and there are some initiatives around some of those types of things. I'm not sure, have you guys shared the bridge video, the 1 minute and whatever, 2 minute and 42-second bridge video about palliative care that actually MNHPC commissioned back, oh, Janelle, do you remember when, like 2017 maybe? Something
It's
like
been a
that.
few years. Yeah, I don't think we've shared that yet.
Yeah. Oh, I just took it out of my slides because I thought you would have. So that, which is actually a great, maybe we can find it while we're talking, but we've used that. I actually just sent it last night to my marketing person and said, hey, next week is National Palliative Care Month. Can we place this again on our Facebook page, on our website, the public facing website, to just kind of remind people about some of these things, to do some ongoing care. And then we've done speaking. Cindy and I have done some speaking at women's health initiatives at the college or things like that. We've done some
To the
conversations.
Lions. To
Yeah, we went to
the,
churches, we
yes.
went to Lions, we went to
didn't we do it to school?
we did something at the school, we did something with the Ministerial Association. When we periodically bring LNIC trainers into our community to teach staff, we will invite community. So like when they do the section on spirituality, we will invite our local Ministerial Association in. Again, that's a group of people who need to have these myths sort of dispelled and have some good conversation around what that looks like. So we've done a lot of different things as they come up. But again, financial considerations are always tough. Finding time, access is tough. Administrative buy-in. For me, this was actually critical. And again, having you guys understand a little bit about critical access, the financial considerations when you are a critical access hospital and implementing palliative care, which is working on reduction of ED visits, reduction of length of stay in the hospital, reduction of ICU stay, literally goes against everything that a critical access hospital gets paid for. And so for us to have administrative buy-in from our previous CEO was instrumental for understanding that, and he really had the foresight to understand well before it was the in thing, before it was mandated by the Accountable Care Act, about really taking care of people, not just when they're in our building, but as a community. And he had the foresight to understand that this was what was right. And if you build it, they will come. And I think, I'm grateful that he was right about it, but this has always been the sticking point for small critical access hospitals to build palliative care, because we're actually taking business, we hope, out of the ER, and we're asking them to pay for nurses, social workers, chaplains that don't bring in money. They're not profit producing, so it can be tough. But we looked at it. Our mission was around, we were one of the very first medical homes that was certified in the state of Minnesota. We had a robust joint replacement program called our Joint Connections. We have a very robust obstetrics team. We deliver more babies than some hospitals around here that are twice the size of us. Our palliative care and now our ongoing oncology care. So we continue to be mission driven around comprehensive care for the community, not just the people who come in our doors. So the financial considerations, actually, I'm not going to go into a lot of that because you guys really understand some of that. And as we are a decade plus into healthcare reform, we know that hospitals are responsible for the total care of patients, not hospitals, healthcare systems for the total care of patients, not just when they leave, when they're in the doors. And we don't discharge them from our care when they walk out the door. They continue to be part of our care. So I think this works really well. And I continue to focus on the quadruple aim, which I think I have in here. Patient-centered, quality-driven, cost containment, and improved provider experience. And I've been talking about the quadruple aim for longer than I think before it even had a name, because it was always the triple aim. And I kept coming back to providers are frustrated with quality of care at end of life too. And so trying to help them have a better experience and feel like they're actually making a difference. I think palliative care can help with that as well. Some
Is
strategy.
there, Julie, is there any particular targeting? You mentioned that you're part of the Alidate ACO. Do those patients float to the top in terms of your identification for palliative care services, or is there any kind of
That's a
direct
great
connection
question.
there?
So not yet. I've
Okay.
had some ongoing conversations with them. This is really a capacity issue right now for me. I've had some ongoing conversations with them earlier in the year because they have a specific product of, and I can't remember what it's called. Iris, maybe, that identifies people high risk, and it simply looks to see if they have advanced care plans done. And so we've had some early conversations around this. They have, in fact, I was just looking at some of those emails last week, and I realized that they hadn't circled back with me since this spring about some of those things, and looking at, they would be willing to actually do some of that remotely for our ACO patients. But I had struggled with cold calls. And so I had requested that we don't do that as an automatic thing, but we haven't figured out a system to that. So it's in the works, it's somewhere in there. The other thing that I will say, it's not an ACO, but we are experimenting with a product called Acclivity, which looks at payer information and stratifies people as high risk to be needing hospice or palliative care and some other care service lines. And we are just really starting to get into the weeds on that. So it does some things like it looks at their DME, it looks at their ED, their hospitalizations. It looks at their diagnoses. And so if they have a certain number of HCC codes, it looks at they do a estimated palliative an estimated PPS to kind of give an idea of where they're at. It looks at their pharmaceutical use and the types of drugs they have. So it's all payer based. So it's all claims based. And so it looks at some things and says, hey, these 10 people are rising to the top. And then we have a team looking at them. I take a peek at them and I'll go, nope, they're already in the care center. They're already getting everything they need. And I take people off that list. And then we walk through our community-based people or someone who might need some extra help. So we're experimenting with a couple of different data coming into us and helping to stratify that. It's exciting, but it's also very cumbersome and the capacity is tough. So
Yeah,
hopefully,
thanks.
and that was something obviously we weren't talking about even 5 years ago, probably 3 years ago.
Yeah.
I feel like I want to crawl through some of this. So we've talked kind of about our team, our interdisciplinary team, education. These are some of the things I've kind of touched on. So staff, we've used ELNIC, we've used Stratus, looking at CAPC, PCLC, PC Now, the Palliative Care Network of Wisconsin. If you haven't connected with them, they're a great resource. I probably weekly send one of their fast facts to one of my nurses. Just like, here, you're going to go talk about in fact, right before I got on this phone call, I was talking to one of my nurses. We're going to start methadone on a patient. I'm like, here's what I want you to know about methadone. When you go talk to them, I don't have time to do that right now. And helping those, they're just some great resources on education. We've done some webinars, we've done webinars for others, and then we've participated in webinars as an education piece. We've done some echoes, grant funded courses, even simply developing an order set for our inpatient team can help them remember to take care of people in a different way if you have some order sets put out. We do an annual Season of Lights Remembered ceremony, so people also get some education about hospice and palliative care there as well. 8 domains of palliative care. I'm assuming you guys have had some conversations around the National Quality Forum and this structure. Have you guys done some of that? So this is probably old news. I love that document. I think it's it's kind of, I don't know, my Bible maybe, because I can go back to it to remind myself there's some things that we can add to add some structure. And then quality metrics. This is hard. This is super, super hard. If there was anything I learned, I would have tried to build this in right away, but you often don't know what questions you want answered when you're starting. And so that's only in retrospect that I can look at that. So I'll show you those numbers here in a second. Leadership, we've talked a little bit about. Look for your leaders in maybe places that you don't necessarily expect. And maybe look for kind of developing some champions where they may not know that they need this. I think your geriatric people, and a lot of geriatricians are sort of mid-career people. If they're like me, I started here 27 years ago. I did moms and babies was the primary, and they've all aged with me. I continuously see people who are going off to college and their parents who are now retiring. And so I've aged with them. So I've become much more of a geriatrician than I was when I first started. Look at some of those people, look at your APPs, look at your hospitalists, do some education with them, see if they're interested. Look at your discharge planning team. You might be able to identify people that haven't self-identified, and sometimes they just need a little extra education. So that's the piece around creative staffing, hardwiring palliative care principles. I think this is an ongoing thing. Every time we change something in our system, we have to re-hardwire some of these things, and turnover is obviously a big deal. Workforce development, I spent a little bit of time talking about that too. I think take advantage of the students that are coming through your systems. And so when you are working with these health systems, ask them about who's coming in, who are they educating, and see if they can hardwire some of these things as well. So this is data. So a long time ago, we worked with Stratus on a very brief data collection thing. And I had to laugh when I looked at this date. I'm like, that was 12 years ago. But it was very eye-opening for us, and it was very fun. So we looked at, this was all hand pulled out. Poor Cindy did a lot of work, and we pulled out our data of hospitalizations, ED visits, and lengths of stay. So here's our ED numbers before somebody was admitted to palliative care, and after. It's kind of black and white. You take a peek at, here's our inpatient stay, and here's our inpatient days. And so it does make a difference. This isn't everything that critical access hospitals want to see, but I think it's important in the overall look at things. All right, we talked a lot. Ooh, I did get through this. What do we want to chat about? And I've got time, since got a little bit of time. I don't know what your next plans are at 10, so we've got some time to kind of walk through this. And I can stop sharing, I think. Here's my resources.
First off, I'd like to just say thank you so much for sharing all this. It's been really, really helpful. Melanie, do you have any questions?
I do. Relative to advanced care planning, do you all use Respecting Choices, or have you created a homegrown version, or some other state accepted?
So we do Honoring Choices, which is the Minnesota version of Respecting Choices. I've sat on a couple of different reiterations of the Honoring Choices delineation too. They recently revamped some of those things, and I sat on that board to kind of work through some of those things. That's what I have in my office. That's the training we've provided often in the past. Again, we don't have a real strategy around doing that annually. I wish we would, but it's really workforce dependent. But yeah, that Honoring Choices is what we probably use the most.
Okay, thank you.
We also do like to do the post, if at all possible, with our patients. It's just the next step, but some patients are very adamant about what they want, and so they want that order in their home, even pre-hospice.
Yep,
So.
absolutely.
So is the post in Michigan, it's a voluntary thing, and is that, I assume that's probably true there as well?
Yep, it's voluntary, although I will say if they are admitted to our long-term care or any of our assisted livings, we do a post with them at that time. That is part of our admission process, and it does follow them. I review those pretty regularly. And in home care, I don't know if I can say it's required, but it is, we are probably fairly universal in having something done in our home care population.
Okay, thank you.
Mm-hmm. And we, of course, support a statewide post registry, which has not yet happened. Our Palliative Care Advisory Council is also supporting that, because that would be really nice.
Well, our Department of Health and Human Services has been working on kind of the implementation of it, and obviously an education rollout. But they just presented they have a commission that they put together, a committee to work on it, and they just presented those to the Michigan Health Information Technology Commission. So I might need to find out how that went, because some of those kinds of issues were in their recommendations.
So for developing a registry for a
I
pulse?
think that's one of them
Yeah.
is.
It's
And
key.
there was
Yep.
an effort, we have a Michigan Health Information Network. I think that originally there was an intent to put them in there, but I think that's kind of fallen apart. So I'm still trying to piece that together.
You know, it sounds super easy to do in this day and age when we have all this quote unquote technology and we're putting people in space and doing all sorts of things. This doesn't sound like it's that hard. It is amazing at how cumbersome it can be and it's not that you can't build it, but how do you maintain things and how do you make sure, ensure its accuracy? And I think that's where it's hard. You know, I keep looking at the immunization registry that I access every single day, and the data I get, like I can see all of your immunizations, and I just think, we need to be able to do that, and yet we're just not quite there.
Yeah, thank you.
I think, does anyone else have any questions for the team?
Oh, Aaliyah, this is Jill. There was a comment in the chat that Renee had to hop off for another meeting. But just indicated each year we do a annual rural health conference in the spring. So we do 2 conferences, one that's more geared toward our critical access hospitals, and then one that's in the spring that's a little more diverse in terms of our primary care, as well as our hospitals, EMS, local public health, kind of that more robust model. Love to do like a conference presentation or have this spread a little more broadly across our state. So something to consider.
I think Stratus periodically has, they present a lot at our rural health conference, and we've had some sort of presence from a palliative care standpoint multiple times over the years. I don't know if that's an ongoing thing all the time, but I think they've done a great job. And I think the rural health conferences are an ideal place. We've also presented at the Minnesota Hospital Association, and not me personally, but I've requested some, when I used to sit on our board for the hospital, I requested some of that education, and they actually, MHA actually engaged in some of those conversations as well.
Perfect. Thank you again. This information has been fabulous.
This was amazing. Thank you.
Absolutely. Good luck. And I'm really excited that we're actually talking to some of the thought leaders in this, as opposed to, and not that I don't love talking to individual health systems, but sometimes it's a little bit overwhelming about what you can and cannot do. And I actually think this is a great group of people to sort of help inspire and help them become a little bit more creative about things. This is lovely. You guys are doing good work, and just keep working. Just keep doing it. It's super hard.
I guess what I'm wondering is, do you have any like words of advice for trying to engage for the first time? Because I think our next step is to go out to those possible communities where we could embed these palliative care services, and somehow we have to say, hey, this is what you want. This is a really great program, and how do we create that buy-in?
A couple of things. I think our health environment now is in a little bit better place than it was pre-Accountable Care Act. And I think most places get the commitment to ongoing care coordination, however you want to talk about that. So whether it's RN case manager, however you want to do that. And so I think if you can kind of envelop that, and this is a specific sort of specialty for people with serious illness, I think telling a story. We say this over and over again. If you've got a story, if you've got someone that you can point to that had either excellent palliative care or lack of palliative care, or even looking at trying to bring those 2 stories together, maybe ask within that community if there are some stories that can sort of illustrate it. People don't know they need it until they need it. People don't have that language around it until they need it. And so you have to tap into the people who already know some of those things. I think that'd be one thing. I think when we talk about taking care from kind of womb to tomb, it's really sexy. I say this all the time to my team here. It's super sexy for us to talk about like OB and peds, and our new, like our orthopedic program is expanding great. And it's super fun to talk about, like, helping kids stay in athletics, and even our cancer care is kind of sexy because it's just like, we are bringing state-of-the-art cancer care to rural Minnesota. And then you have this section of life. And I think even sometimes looking at the terms that we're using, I love the term palliative care. It means a lot to me. I understand it. But sometimes you have to rebrand this as serious illness care. I don't know if, I mean, we've gone back and forth over time. Just even that term turns people off. And so depending on who you're talking to, maybe introduce this as, I kind of talk about serious illness care as being the one name, and palliative care is kind of the behind the scenes name to sometimes when I talk to staff about it, just because it can turn even really highly educated people off. And that's really sad. So palliative care suffers from that identity crisis, I think. And so acknowledging that, dispelling some of those myths.
Thank you. Yeah, I know that some of the palliative care doctors that we've connected with in Michigan, they have one of them calls it like quality of life care rather than a palliative care, just to kind of help with that communication and understanding within their community.
The reason I haven't moved to all of that in general is because then people will sometimes say, but I need you guys to take care of this, and it might be not they identify it as quality of life. So that maybe that's where you get into that strictly pain management versus palliative care. There's, to me, there's a little bit of overlap. And of course I want comprehensive care for everyone, but I can't take care of every single diabetic foot ulcer as in palliative care, right? So trying to be careful with that.
Yeah. And I would say another thing that, and maybe if you could provide some insight into this, that has been a big conversation, especially within our advisory council, has been the reimbursement model for palliative care. So obviously we've kind of talked about today, obviously we're kind of taking away from that model that critical access hospitals are able to make their money. So how does that kind of work on the flip side? Like how are you guys billing or?
I would love to have a great answer for you. I thought that this would not be a very hard thing. When I started working with the Palliative Advisory Council for the state of Minnesota, the Legislative Advisory Council, I was like, oh yeah, we're going to be able to get this. We're going to be able to come up with a plan. This is complex. This is really hard. We've worked with Tori Fields out of California looking at some of these models. It is hard. I think, again, some of these are going to be pilot programs. I'll be honest, I've kind of given up on it in my own little world because I can get reimbursed for it. Our hospital system has invested heavily in the teams. There isn't reimbursement from the standpoint of that we can track, but we can track our quality, and that is actually probably more important. So it's tough. I don't think this is going to be an easy decision or an easy solve, and Status probably has more knowledge on that from a payer standpoint. I mean, even the conversations we've had with payers, we had a contract through UCare after we graduated from Stratus, and UCare said, hey, we'll try a pilot project and we will pay you for some things. We didn't have a ton of UCare. We didn't access it very much at all, but they were willing to sort of say, we'll give you blank dollars for 3 visits by a social worker and a visit by a chaplain and something from an RN, but that was all pilot project stuff. It wasn't sustainable.
Yeah, and when it's inconsistent across different payers and you only have a handful, it's really hard to kind of keep. Yeah.
And because there isn't regulatory and certification around this, it also becomes hard to tie some money to it. I do think payers will get to it, but I think it's going to be, I don't think it's necessarily going to be palliative care specific. I think it's going to be care coordination specific. Like I see those lines blurring more and more over time. So it'll be interesting to see where that ends up.
Yeah, thank you.
Dr. Benson, this is Jean. I just had a question about you. Lakewood looks to have a continuum of care. So you do palliative into hospice. I wonder, how do you work with other outside hospice agencies then too? Is that transition?
Yeah. Actually, we do, especially some of our people who live a little bit farther out. Their local hospice agency may not be us, depending on where they live. And so we do referrals into area hospices. You might be able to talk a little bit more about what that looks like.
Yeah, so when they are in need of hospice, we of course have to ask them which hospice agency they want, and we'll give them a list even. And if the ones that are further out, we will send that referral to them. and then it's taken care of by our social worker, and all the information is sent to them. Some people want a nurse to nurse,
A warm handle,
report.
yeah.
It doesn't always happen because some people are like, no, we'll gather our information. But yes, absolutely. We have one that we use most, besides us, we have 3 others probably that we use the most in the area.
Okay, so I think that our biggest hospice agency is Hospice of Michigan, and I think that they have a palliative care program. So I just wondered how that works. I mean, I don't know about our critical access hospitals because I'm not as involved with, because I'm in a different role, but I just wondered if it makes sense for some of that to be for the critical access hospitals to work with those organizations as well.
I think sometimes we suffer from having everything under one system to some degree. And so we haven't maybe been as good about partnering with some of the community agencies. We initially tried reaching out to like some of the public health stuff. Again, they had capacity issues. We included them very early on in some of the education pieces, offering some things to them, capacity issues. And so it wasn't necessarily high on their priority list. But I do think partnering with some of your agencies that can do palliative care, and again, how they define it might be a little bit different too.
Right.
But if they provide home care and hospice, they can do palliative care and they can get reimbursed for it.
Okay, thank you.
They just might not bill it as palliative care. They're just going to bill it as regular home care and add in, which is what we do, and sort of gratis do some social work and chaplain work.
Yeah, that's what I was wondering, is because hospice has the volunteer model, but if you utilizing your home care for the and then there's also that sticky piece of you have to have somebody in the home to get hospice care, and so many people don't have that piece. So palliative care feels like a
absolutely
bridge as well. So thank you.
And that's why I like the bridging idea to some degree.
Yeah, I want to watch that video.
Yeah, it's good.
Thank you.
So I have a question going back to what you said about when you try to capture the savings from reduced emergency room visits and inpatient stays, but that impacts potentially the income. How did you work through that?
We didn't.
I almost added that to say, or didn't.
Yeah, we really didn't. I mean, again, I think Cindy and I early on kind of kept waiting for the other shoe to drop and for them to say, oh, we just can't do this. And really, especially during COVID, I believed we would be okay. But I think maybe Cindy said, we're going to be cut. There's no capacity. And for how long did you actually do home care?
It was a year. So
this poor woman went back to home care
and hospice.
and hospice. So she was reassigned for a period of time, but our CEO continues, and we've now had a transition to a new CEO, and I met with her right away and we work with this, but he just said, this is right. And so it wasn't really about capturing those savings. And that's probably part of the reasons we don't have some of those quality metrics, because it didn't matter. He knew, again, he really, really, really knew this is what was right for the community. And that was the investment before it was the thing that was mandated by the government, before it was the thing that you reported off because you were taking care of your community. This was his philosophy.
Mission driven.
Absolutely. So I'm lucky. And so that's been one of the frustrating things when we have presented, over the past decade, is a lot of people don't have that kind of leadership. And so I kind of get to say we were just lucky, and that's not always very inspiring.
Well, and I think Tim was also really good about recognizing that the importance from a marketing perspective. I mean, like market capture share, like you guys provide amazing care, and that keeps more people in your community, which is actually both mission driven and also from a financials perspective. If people aren't driving 30 miles to Brainerd to get their care because they can get it in Staples, it's having that vision is, I think, challenging when you're a CEO and you're just trying to make sure you can keep the doors open and the lights on.
So, again, that leadership buy-in becomes so really.
I don't think we could have been as successful or even successful without that. I think if I had to prove that over and over and over again, I don't think we would be in the same place. And I will still say, I mean, Cindy and I don't get to see each other as much as we used to. I think we continue to be in transition. This does not look the same as it did 2 years ago, as it did 5 years ago. I mean, it continues to morph and change. When we have a new palliative care doc coming in and this is all he's going to do, I got a little ego thing going on here. I don't know what it's going to look like. I'm a little nervous.
I want a job. No.
Yeah, I mean, we're excited about it, but I also am nervous about it. You know, I'm also in the eve of my career. I will be looking at retirement at some point in time. Some days earlier than others, but what does that look like? I'm worried my hospice might close. I don't know who's going to do some of these things later on. Like, you know, so there's all, this is an ongoing thing. You don't just build it and it's done.
Yeah.
It morphs a lot. Yeah.
A lot.
Yeah. I used to run a nonprofit, and you know, I just retired and went through the same things, which is like, is it going to be here another 80 years? I don't know.
I think sustainability isn't something we thought a lot about early on, because I always had that commitment by our leadership. I think the sustainability that I'm looking at going forward is not about leadership anymore. It's about some of that blurring of lines between care management, so medical home and comprehensive cancer care management, and some of the, like, there, I think there's some more blurring of lines there, and I think maybe that's where I'm worrying about some of our sustainability too, because the rest of the world is kind of catching up to this idea about comprehensive care, right? And they weren't there 10 years ago, and now this model is for the fact that we could come out of our long-term care and not have to do that ongoing reminder of care speaks to the fact that we've hopefully educated. Like, my staff will come to me and say, because I'm there every single week, and they come and say, okay, so I had a goals of care conversation with so-and-so, blah, 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 they want this. I'm like, sweet, I didn't have to do that because it's just embedded, but it wasn't 10 years ago, 15 years ago. And so sometimes you suffer from identity crisis that way too.
Yeah.
Thank you so much, Dr. Benson and Cindy. Something that also you've kind of mentioned is like that chronic care management. And I know that Jill has done some work with that chronic care management space as well. So does that play into like the reimbursement models as well, like with like CCM codes and anything like that? How does that, like that chronic care management, or how do you think it'll play into your model moving forward? If you had to predict the future.
I don't know. We
started charter.
We just have a little bit of new middle management leadership change in the past few months, who's now in charge of care coordination, right?
Mm-hmm.
And she is looking at both the palliative care team and our non-palliative care management, and looking at what can be married and similar. So looking at some of our, time billing, we're looking at some of those CCM charges, right?
Yeah.
And so using some of that in palliative care, we expect that to continue to build and become more robust over time. I think we'll see that similarity, but I don't know that I understand all of that.
Yeah, thank you. I'm thinking, all of my coworkers could probably tell you that I'm thinking about 1,000,000 miles ahead. So I'm thinking about that question and answer time with, our hospital systems in Michigan. So, and just wanting to think of a way to market them. But thank you so much for your time today. This has been absolutely fantastic getting to hear all of your insights. So don't be surprised if we reach back out, because I'm sure we'll have questions.
We're good with that. Have fun, you guys. Thank you very much. We appreciate it.
Thank you guys.
Thank
you.
Nice to see you.
Thank you.
Have a good weekend.
You too.
Bye-bye.
Bye-bye.